great pleasure to be here, and thank you so much all for sticking around for my talk. So now for something completely different, I suppose. So I'm going to talk to you today about the idea of mindfulness and mindfulness-based interventions, and because this is quite a mixed group, I'll spend a bit of time talking to you about my understanding of what we think mindfulness is, so we're all on the same page there, and then what are mindfulness-based interventions, and then our specific adaptation that we call mindfulness-based cancer recovery, and then two trials that we've done over the last, well, one that's completed and one that's in progress. So I like catchy acronyms, so we call them Mindset and Match, and I'll tell you the results of Mindset and then tell you about how what we learned in Mindset is feeding into what we're now doing in Match. All right, so what is mindfulness? How many people are familiar with this idea? Just wave your hands. Okay, so a number of you, but it's new for some of you as well. So it's a fairly simple idea. It's just about paying attention on purpose in the present moment with an open and accepting attitude. So mindfulness is both a way of being in the world, so we can be more or less mindfulness as we walk through our day. It doesn't take extra time to pay attention. So it's a way of being in the world, but it's also a practice that we cultivate through mindfulness meditation. So the practice of mindfulness helps us to be more awake and aware in our everyday life. So who's more mindful here, the person or the dog? So the dog is actually in the present moment and seeing what's there. The person's mind is full of all sorts of stuff that's actually not in the present moment, all sorts of judging and evaluation and analysis. So that's a way of being more or less mindful, and here's an illustration of the practice. Of course, you don't have to sit on a rock overlooking the sunset to practice mindfulness meditation. Probably doesn't hurt. All right, so if we're not, so mindfulness, again, as I said, it's simple, but it's not easy. It's kind of not our natural way of being in the world. Why not? Well, what is our mind doing if we're not in the present moment? Turns out we have anywhere between 50 and 70,000 distinct thoughts every single day. And when you put trackers on people, which researchers have done, and ping them throughout the day and ask them what they're thinking about, it turns out about half the time we're not in the present moment. So our minds are wandering somewhere or other. And in addition, when we are not in the present moment, or when we are in the present moment, we tend to be happier. So they ping people about their moods. Why would that be, potentially? Well, when we're not in the present moment, where are our minds? Often, and maybe you've had this experience, like this woman, maybe you're ruminating about the past. You're thinking, oh, why me, or if only I'd done or said that, or feeling angry about something that's happened and having regrets and feeling sad and depressed. Or maybe you're like this fellow. So his mind's racing off to the future, right? He's got this really long to-do list. How can I get it all done? And what if this happens? And what if that happens? And oh my God, how am I going to manage? And he's worried and stressed out. So mindfulness is really about this idea of letting go of our tendency to ruminate on the past and worry about the future, and train ourselves to be a little bit more in the present moment. Because as I said, in the present moment, things tend to be more or less okay. So what are the components of mindfulness theoretically that we talk about? So we've got a three sort of factor model. We call it the IAA model. So the first letter, the I, is the intention. This answers the question of why do we practice? You know, in our simple definition, we practice on purpose for some intention. So the intention doesn't have to be very goal-directed. It can be, my intention is simply to wake up to my life, to be there when it happens. This intention is kind of like a compass direction that steers us where we want to go. So the what of mindfulness, the actual heart of the practice, is attention training. So we're learning to pay attention, and it's a skill. Just like you have to, if you want to learn to play piano or be a good tennis player, you can't read a book about it. You can't just wish yourself into playing piano. You have to actually practice. And it's the same thing with mindfulness. You have to sit down on a regular basis and practice paying attention in the present moment. It actually rewires your brain. There's a lot of neuroscience behind this. And the third component that's also really important is the how do we pay attention, the attitude we bring to the practice of mindfulness. So we talk about an open and an accepting attitude, a non-judgmental kind of approach that's kind and compassionate towards ourselves within the practice of mindfulness, but also as we move throughout our daily life. So there's also a lot of misconceptions about mindfulness. So what mindfulness is not, it's not just relaxation. So being awake and aware in the present moment isn't always relaxing, because often our experience in the present moment can include difficult emotions, difficult things we're going through. So it's not just relaxing on the beach, although sometimes the relaxation response is induced by mindfulness practice. It's not a form of hypnosis where we're trying to sort of control your mind and direct it in certain ways. It's not a religious practice or a form of prayer, although some of the background of it does come from Buddhist philosophy and practice. It's now in the Western world practiced in a very secular sort of way. So there's also this idea that, your mind becomes blank and you're floating on a cloud and everything's wonderful. That's not what mindfulness is about. As I said, it's about being present with your experience and creating a safe container for all of the emotions that we have. So here's my shameless plug. I've written a book called The Art and Science of Mindfulness. Actually, it's out in second edition, just came out in 2017. This is for clinicians. So it includes chapters on, theories of mindfulness, how to be a mindful therapist, and different mindfulness-based therapies. So you can pick that up for more background. Now, sort of the adaptation of mindfulness that's most commonly used in the West and in medical settings, as well as now in schools and all over the place, is called mindfulness-based stress reduction. So this was a program developed by Jon Kabat-Zinn in the late 1970s, and what he did was really take the philosophy and the ideas around mindfulness practice from religious traditions and combined it with sort of modern-day stress reduction and put it together in a package. So it takes, what happened there? So it takes the mindfulness meditation and combines it with the stress reduction. It's an 8-week sort of structured program. And so he started using it again in the late 70s, early 80s, and since that time it's been adapted to a gazillion different settings. And there's this great organization called AMRA, the American Mindfulness Research Association, that has a compilation of all the mindfulness research that you can access at that website. This book, Full Catastrophe Living, was the book written by Jon Kabat-Zinn that originally describes the program. Great resource if you'd like to learn more. So again, mindfulness is a fairly new construct in sort of Western psychology, but you may have seen, it's sort of taken off lately, right? It's the latest fad. So if I ask you, how many mindfulness research studies in scientific journals do you think were published in 2015? Throw out a number. 8. 600? What did you say? 8. Well, you're right, but in the wrong year. So I'll show you a little graph here, if I can get it to come up. There we go. So from 1980 to 2015, you can just sort of see this exponential rise. So, there were actually, when we published our first article in the year 2000, there were 12 in that year. A few years earlier, there were 8. But now you can see that back in 2015, up to when this graph goes, it's almost 700 different articles on the concept of mindfulness, and that number is only growing. Whether that's a good thing or not is a whole other topic of conversation that I'm not going to get into. But our program at the Tom Baker Cancer Center in Calgary was developed in 1996 by 3 of my colleagues. I arrived a year later, and they had based the program on their own personal experience with mindfulness and yoga. Because each of them had their own personal practice, and they had a conversation one day saying, what do we do when times are tough? Well, we turn to our meditation practice, so maybe we should think about training our patients in this. So I showed up a year later in 1997, and we refined it based on the model from Jon Kabat-Zinn and the University of Massachusetts. So our program is a clinical program. It's been available since 1998. It's open to cancer patients and family members. We do it in groups of 15 to 20 people. We offer about anywhere from 6 to 9 groups per year. So we've had about 2,500 people, I guess, through since that time. So it's an ongoing clinical program, and we embed research studies within the clinical program. So another shameless plug, we've written a book called Mindfulness-Based Cancer Recovery, which is what we ended up naming our adaptation of the program. So this is a patient-centered manual that anybody can use to sort of cover the full curriculum with guided meditation, so they can do it as a home study program. So our program is an 8-week intervention. Our weekly meetings started out as an hour and a half. They're now a little longer, an hour and 45 minutes. We typically have 2 instructors. So each class is a discussion of sort of theoretical material, checking in on home practice. We incorporate mindful yoga, or mindful movement is half of the practice, and the other half is different meditation techniques. And we cycle through a series of different techniques. The patients get a booklet that outlines the program, includes a reading list, and they do home practice every day with CDs that we provide them. They keep track of the time they spend in meditation, and we have a 6-hour silent retreat between weeks 6 and 7 where we get together and incorporate all the different practices they've been learning over the weeks. So it's a very sort of multi-component type of program. There's many different elements that you could choose to dismantle, I suppose, but we have not gone that way. So the overarching theme is mindfulness. How can we be applying mindfulness throughout our life in different ways? We do teach them about relaxation and the relaxation response, how to control our level of physiological arousal if we choose to. There's the component of gentle yoga, which is, again, very important, that embodiment of the practice. And for people in our program, they've often been through surgery or chemo or radiation, and it's a reacquainting with the body, reconnecting. There's a lot of theoretical material around psychoneuroimmunology and the mind-body connection. We teach them some visualization and imagery strategies. There's also some cognitive coping in there, a little bit of CBT about understanding the stories we tell ourselves and what the impact is on our experience. And of course, there's an element of personal empowerment because we're teaching people tools and techniques they can use for themselves. And there's an element of social support because it's done in a group setting, and that actually is very powerful as well for people to be sharing this experience and this learning with others in a similar situation who understand what they're going through. So this just shows you what it looks like. Here's the group at the beginning, just sort of checking in and doing some didactic stuff. You can see them doing a bit of yoga. You know, some people will be supporting themselves with a chair or the wall. And then doing meditation. Again, some people will sit on chairs or stools or, you know, in various different modalities, and we offer adaptations for any level of functional ability. Okay, so we've done lots of studies over the years, and this slide just sort of summarizes some of the areas we've looked at. We've also used lots of different methodologies, so qualitative work, pre-post studies, randomized waitlist controlled trials, and have looked at a range of different symptoms that are common in cancer patients and survivors, beginning with things like reducing stress, improving mood, decreasing anxiety, anger, depression, symptoms like sleep disturbances and fatigue, very common in cancer survivors. And then we've looked at a bit of the mechanisms of change, so emotion regulation strategies like rumination and worry, and shown that those kind of things decrease as well. We've also looked at these ideas of flourishing and growth, and that there's a concept called post-traumatic growth, where a difficult experience like cancer can be a catalyst for change. We've looked at spirituality, which is about a sense of connection with something larger than oneself, a sense of meaning and purpose in life, and various ways that we've measured the capacity to be mindful. And those things all improve as well. We've also been interested in biological markers, so we've done things like look at blood pressure and shown that people who are prehypertensive show decreases in blood pressure. We've looked quite a bit at cortisol slopes. In salivary cortisol, that's a stress hormone measured across a number of days. And we've also looked at inflammatory markers, cytokines, and I'll tell you about the telomere length stuff in the next study. So you can get all those papers on my website, and I think I've got that on the last slide as well. So I'm going to tell you about mindset. Just going to grab a drink. Too much talk. All right, so this was a randomized controlled multi-site trial of mindfulness-based cancer recovery versus supportive expressive group therapy. So the idea is to do a comparative efficacy study where instead of Ken set me up for this, right? Instead of an artificial sort of attention control, we compare two real interventions that are clinically offered and that our patients may have access to see if there are any differential outcomes. And this was in breast cancer survivors. So we thought it was innovative for a number of reasons. We included only distressed participants, so they had to be 4 or higher on a 0 to 10 distress thermometer. This excludes 70% of the population. Only about 30% meet that criteria. And so we did this comparative efficacy, I think, more than effectiveness, of these two, both empirically supported treatments. And we included a third control arm that was a minimal intervention control. They had a 1-day stress management seminar. And then after that pre-post sort of 3-month period, they were re-randomized to one of the 2 active interventions. And I'll show you the flow chart that depicts that in a bit. We had both psychological and biological outcomes. And it was a relatively large study in this area so that we could look at moderators and try and, this idea of personalized medicine. So are there baseline characteristics of individuals which might predict who's going to do better in one of the other interventions? And we followed them out for a full year after the program. And I think it still is the largest study of its kind to be published in this area. So the other intervention, as I said, is empirically supported in and of itself. It's called supportive expressive group therapy, developed at Stanford by David Spiegel and Irvin Yalom in the late 1970s. Based on principles of emotional expression, engendering mutual support, many topics discussed, often difficult emotional topics like coping with a changed sense of self and body image, and ideas about death and dying and detoxifying these difficult feelings. And I don't have the slide, but the groups were matched on contact time of the intervention, even though the structure was slightly different. So what were the research questions? What are the comparative changes pre to post among the 3 groups? On the psychological outcome variables? On the biological outcome variables? What about these baseline factors that were related to improvements? Could we look at some moderating variables? And then looking at the long-term effects. So I'll go through each of these questions briefly to show you what we looked at. These are all the baseline measures, so the typical sort of things you would look at, the demographics, disease characteristics, and then all the moderators we were interested in. So there's quite a bit of theory around how emotional repression or emotional suppression might tie into people's recovery from cancer. So we measured both repression, which is a sort of subconscious denial of difficult emotions, and suppression, which is purposefully pushing down difficult emotions, trying not to let them surface or to address them. And then we looked at personality factors with the big 5, the NEO 5-factor index. And we also were interested in preferences. So this idea, I guess, of expectancy. And if you're randomized to what you want, are you going to do better than if you get randomized to a treatment that you actually don't prefer? So a range of psychological outcome measures: mood, stress, quality of life. We also measured spirituality, benefit finding, as we've done in the past. We added in a measure of social support, thinking that that may favor the supportive expressive therapy group. And for biological outcome measures, we did salivary cortisol slopes, telomere length, and looked at cytokines. I'm only going to report the telomere outcomes for you today. If you have questions about the others, I can address that after. So let's look at our first research question. So here's the flow chart. So you can see at the beginning we had 273 people in Vancouver and Calgary, 113 in mindfulness, 104 in support groups, and half as many randomized to the control condition, so it was 2 to 2 to 1 randomization. At the post-assessment, here's the numbers. Unfortunately, our attrition was a little bit high, 33%, so about 20% dropped out of the groups, and the additional attrition was people we couldn't follow up with the surveys. So we did intent to treat analysis and tried to control for that missing data as much as possible. So the rest of the flow chart I'll get to in the follow-up stuff. So we're just talking about what's in the blue box for the moment. So here's our participants. We had about an average age of 55, the women, about 2 years since they were diagnosed with breast cancer. About 2/3 of them were cohabiting or married. About 60% were working full or part-time. Another third were retired or on disability. About 3/4 of the women were fairly highly educated, and they were mostly stage 1 and 2 cancers. So if we looked at our primary outcomes, what we've got in these graphs, the mindfulness group is the blue line, supportive expressive is the purple, and the stress management seminar, that's the control condition. So what we see is there's decreases across all 3 groups, but the decrease is larger in the mindfulness group than the other 2. And a similar pattern with the stress symptoms. It doesn't look as big an effect, but we did see a larger decrease in stress symptoms in the mindfulness group over the others. And we see also on the quality of life measure in a per protocol analysis that the mindfulness group improves more on quality of life than the other ones. All right, so I'll give you a taste of the biological outcomes. So again, we measured telomere length, and if you're not familiar, telomeres are these protein complexes, the little red ends of the chromosomes that act almost like that the little end on your shoelace that keeps the lace from unraveling. And so what happens is that they provide genomic stability, and every time the cell divides, the telomeres get shorter with aging. So as people get older, they have shorter telomeres. But having telomeres that are too short can result in DNA damage or cell death. And shorter telomere lengths have been associated with risk for many different diseases, including cardiovascular disease, diabetes. And in cancer, there's studies showing that shorter telomeres were associated with greater risk for developing a variety of types of cancers and shorter survival time once diagnosed. We also know that telomere length is associated with life stress. So people of the same age who are exposed to chronic life stressors like caring for a disabled child or a parent with Alzheimer's have shorter telomeres than age-matched people who don't have that chronic life stress. So we measure this in the blood, and we had data on just the Calgary participants, so 88 women. We assessed the TS ratio, its relative telomere length. And so the reference sample is the average, and basically you're looking at a score of 1 being sort of the standard. Now, what ended up happening when we compared the 3 groups, pre and post, was that there was no differences actually between the mindfulness group and the supportive expressive group. So we combined those 2 into an intervention group and then compared them to the control. So here's the money slide. So the treatment groups, the intervention groups, are in the yellow, and the control in the gray. And what we're seeing at baseline is there's no difference in telomere length between the groups. At post-intervention, this is only 3 months later. And we're seeing a significant decrease in the telomere length of the control participants, but the telomere length is maintained in the people in the treatment groups. So this was an exciting finding. It's the first time anyone had actually seen within a short period of time associated with a psychosocial intervention an impact on telomere length. What it actually means clinically and whether it's a long-lasting effect, we actually don't know. So we looked at then, I'm going to turn to question 3, the baseline factors related to improvement on the outcomes. So these are all, again, the baseline measures we looked at. And we did a whole series of analyses looking at the effect of personality on outcomes, because I really did think that, for example, maybe people who were more open to experience or more agreeable would, differentially do better in one or the other interventions. So we did a whole bunch of analyses. I won't go through the details. There were 28 different analyses looking at all the different predictors, all the personality variables, and then all the different outcomes. But in the end, there was only 2 effects. So basically, contrary to what we expected, emotional repression, emotional suppression, your personality variables had no effect whatsoever on your responses to these 2 different interventions. So what did? Preference. So we look at program preference at baseline, and the most preferred program was the mindfulness in this group. About 55% of people wanted to get mindfulness, 13% wanted the support group, 16% actually wanted the one-day stress management seminar, and 16% had no preference. So then if you look at what happened with the randomization after the fact, only about 30% got what they wanted. So what we were able to do is compare the 30% who got what they wanted, whatever it was, to the 70% who didn't get what they wanted, and look at their effect on outcomes. So it doesn't look like a big effect, but it is significant in that the people who got their preferred program improved more on stress. They also improved more, and you can see this as a larger effect on quality of life. So preference matters. Well, what does that mean for our RCT? Right? The most preferred program was actually the one that performed better. Well, is it because of the program, or is it because of the preference? So, one of the most interesting things from this study was that preference matters, and more importantly in this case, it was more important than any other baseline characteristics or the demographics. So this made us sort of think, well, preference should be measured in future randomized controlled trials at the very least. But better yet, maybe we need to manipulate a preference or make that one of our actual independent variables. So that's what we did. I left out the long-term stuff. I went right into match. Okay. I was going to show you the sort of last question in mindset, which was the long-term outcomes. And basically there, what happened is that over the course of 6 and 12 months follow-up, we had the 2 different groups, just the mindfulness and the supportive expressive therapy. And on every single outcome, the mindfulness group improved more than supportive expressive therapy, and they maintained improvements over the entire 12 months. So now I'm going to go to the match study, which follows from the preference outcome. So this is mindfulness and Tai Chi for cancer health. So we decided to take the sort of best intervention from mindset, which was the mindfulness program, and compare it to a new mind-body therapy that was promising and of interest to our patients. So we chose this Tai Chi Qigong kind of intervention, and we put preference into the design. So it's a pragmatic preference-based comparative efficacy or effect trial where we're comparing some Tai Chi Qigong intervention. So basically people are asked to have a preference for one of the other interventions, and if they do that, what they get. They're not randomized. We have a very broad inclusion criteria, so it's all different types of cancer survivors. We also added in a randomized waitlist component, and I'll show you the flow chart. It's quite insane. And we're also doing screen for distress to include distress participants, in this case with a 6-month. So the objectives are to compare the 2 groups and each other, taking into account a potential moderate and we're physics, and I'll show you in a minute. And we're sort of upping the ante on the biomarker stuff to try and understand a little bit more about what's happening under the skin. So we've got inflammation and different immune processes. We added in a bunch of psychophysiology with the blood pressure, heart rate variability. Stress hormones, again we're doing the telomere cellular aging, and we've added in some gene expression as well. So these are the different measures we're looking at: mood, stress, quality of life, positive psych outcomes. We've added in more physical measures that may favor the Tai Chi. So looking at balance and fitness in addition to fatigue, sleep, pain, the different biological markers I mentioned. And we've also added in some health economic analyses as well to better understand the cost utility or the cost offset of some of these interventions downstream. So this is the flow chart. I know it's super busy. I'm going to maybe walk you through it. So basically the blue side is the randomized side, and the green side is the preference side, and they're pretty much identical. So at the beginning, people are asked again if they have a preference. So if they do have a preference, they go to the green side, and there they choose either the mindfulness or the Tai Chi. So we've got about 600 people we're going to start with. So in an ideal world, half of them will have a preference. Actually, in practice, it's turning out that more of them have a preference, and we'll have to adjust for that. So we've got the mindfulness group and the Tai Chi group, and then within that, they're randomized, even in the preference groups, to either immediate or wait list of their chosen intervention. So here's the mindfulness immediate wait list, the Tai Chi immediate wait list. So the immediate people get the group, the wait list people wait, and they're all assessed post-intervention. And then the wait list people get the group they want, and then they're assessed a second time post-intervention. And then they all have a 6-month follow-up, so a third assessment. And in the blue side, it's exactly the same, except those are the randomized arms. So the hypotheses are that both groups will be superior to control, both active interventions, on all of the different outcomes, we hope, or we suspect. But that Tai Chi would be superior to mindfulness on the physical outcomes related to balance and fitness, and potentially the mindfulness will be superior to Tai Chi on some of the psychological outcomes. And we think that preference will have an effect in that the improvements will be larger in the people who chose the interventions compared to the people who were randomized to the interventions. And we think that effects will probably persist over the 6-month follow-up for both groups. And we hypothesized for the cortisol because we saw the strongest effects on that outcome in previous studies. So we started recruitment last summer in Calgary. We've run 3 cohorts now in Calgary. And Toronto just kind of got up and running, and they're doing their first cohort actually this week, their first groups starting out. So it's going to take a long time to get 600 patients. They'll be recruiting for the next 4 years, so stay tuned, I guess is about all I can tell you there. And so I'll just finish by acknowledging the many, many different funders and collaborators who are required to do a project like this, the teachers as well as the students. And I'll just end with some contact information. Thank you. Thank you.